Hi, everybody. This is Sage Lewis, and today I am with Dr. Ciaccia, and we're going to talk about carpal tunnel today, I hear.
Sure.
So let's just start at the beginning. What is carpal tunnel?
Well, carpal tunnel is a condition whereby there's compression across a nerve that travels through the forearm and across the wrist. And basically, it leads to pain, numbness, tingling, dysfunction, that kind of thing.
It's a wrist thing primarily.
Yeah, I mean, it is, but not the wrist joint proper. The nerve crosses the wrist and it goes through a tunnel system. And as it enters into that tunnel, it gets compressed. And that leads to folks having oftentimes nighttime symptoms of numbness and tingling, waking up, shaking that hand out. The three digits over thumb, index, long, and half of the ring will be involved typically with that numbness and tingling. And as the condition worsens, people will get functional issues. I'm dropping things. I have difficulty, buttoning buttons or, fine motor tasks, that type of thing. And it can encroach pretty heavily upon one's life.
So it's a nerve going through a sheath.
Yeah, a tunnel, a
A
tunnel
tunnel.
that's bordered with bones on one side and a thick ligament on top. Now, within that tunnel, you have tendons that allow you to ball into a fist, those that operate the four fingers and the thumb, and then that carpal tunnel nerve, what we call the median nerve. And it's the median nerve that's getting injured with that long-standing compression.
So it's one place, like it's one main nerve.
You got it. Yeah. The surgical release that, I mean, if it comes to surgery that's necessary, you'll release through a small segment in the hand, maybe about, say about this much. And that's the boundaries of the ligament there.
What does that mean, release it?
Yeah. I mean, basically, you got a mechanical problem whereby there is compression, no different than having a collar on that's too tight, right? So we're gonna take choke off of that nerve. And to do so, we go in using typically scissors or a very fine blade, and we will visualize that ligament and release it by transecting it. So if we're looking at the tunnel kind of in cross section here, you can see the ligament on top. I'm going to divide it, and that's going to open up. And now we have a bigger space for that nerve to live. It's not compressed. It gets better blood flow, and it stops acting poorly. You no longer have the numbness, tingling, pain, etc. Function returns.
So it's the tunnel that's causing the problem?
Yeah, too much stricture in the tunnel, too tight. And so by creating a tunnel that is effectively wider by releasing the ligament to allow for a larger space, that does the trick.
Why does that happen?
I mean, a lot of times we just don't know. I mean, there's several risk factors. You can have thyroid condition. We see it more commonly in diabetics. Pregnancy can contribute. People who are smokers or who abuse alcohol can get it. But a lot of times it's somebody's repetitive action. So, gal who works the assembly line, just doing too much repetitive stuff over and over. And you get swelling around those tendons that I described that also go through that carpal tunnel. And it just sets up kind of this high friction state where you have swelling and friction that builds on itself, and the nerve just has no place to go. It just gets crowded out and compressed.
So could it be sometimes the nerve expands and sometimes the tunnel contracts?
The nerve typically maintains one size. Now,
Okay.
in the most extreme circumstance, when I do a release, you may find that nerve kind of bottlenecks at the site of compression. So, you're looking at the nerve and it's been squished for so long, it physically takes on a more narrow diameter, and that indicates a severe compression. But the nerve just wants to be one size. It gets kind of crowded out, and that's going to lead to that problem.
So like how big is what are we talking about here? The size of a pencil,
Yeah,
smaller?
that's fair. Yeah, size of a pencil is
Uh-huh.
is a normal healthy nerve at that level.
Uh-huh. So you mentioned some symptoms.
Mhm.
Uh is that a good sign to come and see you, or like what are other signs?
Yeah, I mean, I think the biggest thing that drives folks into the office, almost everyone's going to have some type of sensation disturbance, numbness and tingling, and that's enough to get people in. Their hand just doesn't feel right. but frequently I find folks coming in because they're having nighttime awakening. They're just having sleep disturbance, and that begins to interfere with their life, right? Like, so you take an individual and wake them up 3 times a night and do that for 2 weeks straight, that's going to mess with anybody. And so sleep disturbance is a big one. And then functional issue, like, I try and open the pickle jar. I can't do it. I feel like I just don't have the strength. Or I'm walking with my cup of coffee, I just drop it, right? Because your hand is not really talking to your brain. You think you got something, but you don't. So functional issues and sleep disturbance are 2 big ones. And then there's a subset of folks that have pain, right? They have pain, not just the numbness and tingling through these 3 fingers, but they have pain in that distribution as well. Pain along their forearm that will creep along the length of the nerve, radiating down into the hand to radiate to these 3 digits. And for those who have pain, of course, they get in quickly because nobody likes hurting.
Yeah. Like sleep disturbance, like they wake up in pain?
They wake up in pain, absolutely. And they wake up with a hand that's just buzzing, numb, tingly, can't sleep on account of it. And so people come in, they're just like, they do this. Like, it's so routine. People will come in and they're talking about, I got to shake my hand out. I got to get up and hang it off the bed. And they feel like their hand's not getting enough blood flow. Well, it's not a blood flow issue, but it's a common misconception. Folks think that their hand isn't getting blood, and that's why they have to hang it down. But yeah, and that's why folks will use bracing at nighttime. When we sleep, you put your hand or wrist into various positions. You might, you're sleeping like this, or you have your hand over like so. That'll, by flexing the wrist in this position or extending the wrist like this, it raises the pressure in the carpal tunnel and squeezes that nerve additionally. And so if you're doing it during the day, well, you'll just stop doing what you're doing because you're with it, you're awake, and Mother Nature says don't do that, so you don't. Well, at nighttime, you're turned off, and you'll leave it in that state of high pressure for a number of minutes, and before you would otherwise wake up, and then it's really screaming when folks wake up. Yeah. So bracing at nighttime certainly is one of the mainstays for non-operative management. And so folks can get pretty good relief by just getting on a nice nighttime regimen for bracing at nighttime. And they have less symptoms during the day if they're kind to the nerve at nighttime.
I've seen some cashiers sometimes at the grocery store wearing a brace. Is that sometimes what they're trying to do there?
I wouldn't be surprised. And obviously there's a lot of reasons why one would wear a splint to get relief, tendonitis, et cetera. But it may be that the repetitive actions they're doing and keying in, what have you, that's when they get symptomatic. And that would be another time where folks would opt to use their brace because they know the actions that they're doing are going to provoke symptoms they don't like.
Is tendonitis different than carpal tunnel?
Yeah, absolutely. Yeah, tendonitis it's a whole different ball of wax, and there's given the complexity of the anatomy in the hand, there's a lot of different patterns of tendonitis that can come about. I mean, loosely speaking, there is some swelling around the tendons in the carpal tunnel, but different than a straightforward pattern of tendonitis that we would treat typically.
I'm sorry. Do they present differently?
They do. Yeah. I mean, like I said, there's a bunch of different patterns of tendonitis, and probably, a whole different discussion for a different day. Yeah. But there are certainly going to be some commonalities in terms of presenting with pain and dysfunction, but just for a wholly different reason, Yeah. And so one of the other non-operative measures that we typically employ is a steroid injection in the wrist, which sounds bad, but people tolerate it really well. I mean, it sounds like, oh, who wants to be poked in the wrist like that? But I've done thousands of them, and people tolerate it remarkably well. And what that does is that will shrink down the liner around the tendons that also travel through that carpal tunnel. And then there's more space for the carpal tunnel nerve, and that translates into less symptoms. And so steroid injection is commonly used for initial non-operative management of carpal tunnel. And folks can go on to get, in theory, they can get a complete cure. More commonly, they get some period of resolution of symptoms, and then their symptoms will creep back into their life over time.
Yeah. Is it dangerous to let it go too long?
Yeah, it is. I mean, for folks with long-standing compression, there can be some permanence of damage that occurs to that nerve. and nothing's going to bring it back. And so, for folks who are having, numbness and tingling as they just sit at a baseline. So I'm sitting here talking to you, not doing repetitive actions, and my hand is just numb. It's just numb all the time. That's always concerning when I hear that on the front end. And, we worry, is this person going to see resolution of symptoms? Broadly speaking, this is a good operation if it comes to that. And most people go on to achieve a full cure, full resolution of pain, full return to function, good grip strength, et cetera, no numbness, tingling, it all goes away. But certainly we worry about those who have had years of symptoms, who have numbness just sitting at a baseline.
Because the surgery might not fix it and you could end up with permanent numbness and tingling. Is that the risk?
Right?
Yeah,
almost invariably folks are going to get some amount of relief, right? Like, so even for the folks who have, the guy's been ignoring it for a decade and he just has numbness and tingling all the time now. He's got pain, et cetera, sleep disturbance. So we do the surgery and they're going to get some measure of relief. But obviously our intention is to return a perfect hand. I want all numbness and tingling to go away. I want full restoration of grip strength, function, et cetera, and make it a normal hand again. And so while that person with long-standing compression may see improvement, they may not see return to normal sensation because they just waited too long. And so we prefer to get to it sooner than later.
I love doing these shows because I have like personal problems. So when I try, I when I'm doing yoga and I put my hand on the ground like this,
yes,
a lot of pain on my wrist.
A lot of pain on your wrist.
What do you think that is?
That could be various things. Folks can get, you could be engaging some arthritic change in your wrist as you get back in that position. Is the pain more along the palm side of your forearm and wrist, or is it across? Yeah. Do you occasionally get like a little bit of electrical type sensation that would maybe radiate down from your wrist down into the fingertips?
Occasionally, yeah.
Do you ever wake with numbness and tingling in your hand in the middle of the night?
I don't think I do that. No.
Mm-hmm. Well, certainly there are a good solid physical exam would help determine, and there are various things that we do in the office just within a couple of minutes to help us determine whether or not I can elicit symptoms in you. For example, one is we take and we tap along the course of that carpal tunnel nerve, and in a normal nerve, it stays quiet. It doesn't act out when you thump on it. But in somebody who has a baseline of compression, when you tap on it, they'll experience that little electrical sensation down into their fingertips. It just tells you that the nerve is irritated at a baseline. And basically it's a check in the box that says you have carpal tunnel. Now, various other additional physical exam things would help to support or refute that. There's also an objective test we can do to measure for carpal tunnel called an EMG nerve conduction study test. And so that will not only measure, but grade how severe the compression is. So it may come back and say, well, it's not mild, it's not severe. You have moderate carpal tunnel syndrome based on the nerve test. But, that nerve test isn't the most pleasant study. And oftentimes we're able to gather information in a way that allows us to forego the test and, just come to a conclusion on how we should treat it without having that uncomfortable study done.
Yeah. So it wouldn't kill me to come and talk to a person like you about this.
Yeah. One of the things we try on the, say your exam lines up with carpal tunnel, but you're only intermittently symptomatic with specific things like yoga. We would give you a steroid injection, tell you to wear a splint at nighttime, and then, have you follow up in a month or two to chat again and say, hey, was that effective? And if it's effective in a sustained way, then we would keep on with that strategy. If you said, hey, doc, it worked great for 2 weeks, but I seem to be now going the wrong direction again, and we may consider, surgery as a way to provide a definitive relief to what you're experiencing.
Yeah. All right. This is super helpful. So is this your area specifically that you focus in?
Oh, it is. Yeah. Hand and wrist is always been a draw for me because there's good complex anatomy, and we're talking about a nerve here, but I'm an orthopedic surgeon, right? So I still fix broken hips, et cetera, and do all kinds of bony work across the hand and wrist. But with hand, you get to do tendon surgery and flaps and skin grafts and nerve surgery. So it's there's just so many things that are ongoing from the wrist to the fingertips. It's interesting.
Is that how it like went for you? Did you say like in your career, you're like, I want to be a surgeon? Is that the first thing you said?
Yep, that was check one.
Uh-huh.
Definitely wanted to be a surgeon.
And then you're like, what am I gonna operate on?
Right.
And you're
Yeah.
like, yeah.
Ortho was a quick draw for me, definitely. I
Uh-huh.
mean, it's one of those things where you can just take and somebody's got a bad problem and you can put your hands on it and fix it, which is gratifying.
Yeah.
That I like that, and I've always been good with my hands and stuff. I do woodworking on the side, Band-Aid. That's always been good for me. And hand was kind of just that cherry on top, because you get to do so many different little things in a small space like that.
Yeah. If a person wanted to get into this field, like what do you do? Like, how do you learn more about this?
About becoming an orthopedic surgeon.
Yeah, you're like,
Yeah.
wow, I'm listening to this. I want to be like
Yeah.
Dr. Ciaccia.
Come spend some time in the office. That's a great start. Obviously, it depends kind of what level you are, right? So if you're a high school student considering this, then, getting in and just kind of walking around and see what it's like for a day for us. You can even make arrangements sometimes to get a student into the operating room. A little easier years back, but we can make that happen as well, just to truly see what it's like, kind of boots on the ground. But we love having students, and we have them cycle through at various levels all the time, whether they're, in high school or college or, medical students. And of course, residents. I was with a resident yesterday in training who was just following around, just checking things out. So
you're
good.
open to that. If somebody was curious, you'd be willing to talk to
For
them
sure.
about it.
No, I mean, we live and breathe and love this stuff. So happy to have young people they're always asking questions that you never really even thought of. So it's stimulating to have a student around, because they're always, a sponge for knowledge and just always asking why, making you justify what you're doing.
Is it like super hard to become a doctor?
No, I mean, I think
Do you have to be like Einstein smart? I mean,
look, I mean, obviously, being sharp and being good at your studies is super important, but a lot of it is just work ethic and just being a good human being. You know what I mean? So I think there are folks who are smart and could have done it, but maybe just don't prefer to dive in like that. I mean, it's a long haul, and you're watching people, that you like. My best friend's an attorney. Like we came up in grade school and high school together, and he was out getting paychecks and doing well, and I was just burying myself in debt and going the wrong direction, but for the greater good, of course. And like it's not I wouldn't discourage anybody on account of that, but it's a grind. I mean, it's a long haul, and I think the key in that regard is you just take it one step at a time. Don't worry so much about, oh my God, it's gonna be another 6 years of this or 4 more years of that. Just like, what am I doing today? What am I doing tomorrow? Knock it out and keep going.
So it's a passion. Like, you have to be into it.
Yeah, I think so. I mean, I feel just absolutely blessed and lucky to be able to do what I'm doing here. Like it's an amazing thing. And, saw a bunch of patients this morning in the office, going to see a bunch more in the afternoon and help people out. It's good.
Yeah. Like, you're taking somebody that has pain, and I imagine a lot of times alleviating that pain.
Absolutely. Yeah.
That's awesome.
Yeah.
That's
Sure
awesome.
is. Mm-hmm.
Well, I can't think of anything more to add. Is there anything you wanted to talk about that we haven't talked about?
I would just mention about the surgery. I mean, a lot of folks are reluctant to have carpal tunnel surgery if it came to that. So if say it's necessary, we have non-operative treatment that works initially and then fails. Most folks elect to have a surgery, but that's intimidating, right? Like, I don't want to be cut on for something I don't need to have done. And what about anesthesia? Like, the risks of that?
Yeah.
Well, we do this through a more modern approach now. So it's called a wide awake approach to anesthesia. And what we do is basically we inject local or numbing medicine all through the zone where we're going to operate. And then with a numb hand, a patient can go back to the operating room, have their surgery done. They don't see anything. Like, you're not like watching it happen. They're on the other side of the curtain, but we make a, like a 3/4 inch incision in the palm, go in and release that thick band of tissue that's choking the nerve. And 5 minutes later, we're putting stitches and a bandage on, you're out of there. And
Wow.
so folks will literally drive themselves to the surgery and then drive themselves home. That's commonplace. And for those that are just like, well, I don't want to be like, I'm going to be nervous when he's cutting on me, I don't want that. Then anesthesia will be on board and just give them a little something to take the edge off, some bit of something to control the anxiety while we do this quick procedure. Of course, those folks need a driver, but that aside, it's very similar. So what we've done is to kind of eliminate the risks associated with anesthesia. So even a guy with, bad lung disease who can't have a tube down his throat because it's too dangerous, we can fix that carpal tunnel in a safe and modern way and still give them a good result. And so this wide awake approach to anesthesia has been popularized, came out of Canada because of the cost pressures they have in their healthcare system, and they didn't have a lot of access to anesthesia. And then it quickly moved into the U.S. and it gets more and more used every year here. And I gravitated, as soon as I came out of my fellowship training, I started doing it on my own and found very quickly that patients were very satisfied with it, that it's something that they're happy that they can get in and out in an efficient way and not take on those big risks of anesthesia, which for a carpal tunnel, I mean, that's the riskiest part of the whole endeavor.
Yeah.
So we're eliminating that.
So how long has carpal tunnel surgery been a thing people do regularly?
Yeah, I mean, a long time. I mean,
Yeah.
it's something that is, I mean, it's one of the most common operations in the US that are being done today. That's for sure. It's been ongoing for decades and decades. I mean, I did almost 400 carpal tunnels last year, just in a year.
400.
So yeah, I mean, it's not uncommon to show up and have to, I might do 6 or 7 carpal tunnels in a day, just because it's such a common problem. And remember, that's with a target for managing people non-operatively before we do anything. With a lot of folks, the vast majority come in and have some trial of non-operative treatment to try and not just go right at it, right to the surgery, that is. And so it is quite common.
Yeah. So a lot of times you try something that's non-operative first.
Yeah, it's my preference, but that guy that comes in that has been neglecting it for 10 years and has profound symptoms. I mean, if I can look at it and we know it's a loser, right? Like I know I'm going to inject him and he's going to get a week's worth of relief and then he's going to come back and see me and, well, I'm as bad as I ever was, doc. Well, that makes sense. Just cut bait right from the beginning and go and fix it, And so obviously we consider the uniqueness of each case. But it is a general preference to try non-operative management from the get. And then we can both look at each other and say, hey, we fought the good fight here, didn't get there with the simpler option, and now we're going to move and up the ante a little bit and take on those risks of surgery, which we know to be minimal but real, and for the greater good, obviously.
Are you doing these surgeries at your center, or do you go to a hospital?
They're done at the hospital right now.
Okay.
Yeah, it was something that I was certainly working on to try and get them done out of the office, but that's proven unsuccessful to date. So, to be able to move to a surgery center here in the future would help out with efficiency additionally.
Yeah.
But obviously the hospital does provide those sterile instruments and that perfect lighting and all the things you want in a surgery to be able to do it perfect. And while it is a little bit of an extra effort to get, in and out of the hospital, it's worth that additional time, I think.
Yeah. I've talked to some other doctors and we've scratched the surface of like robotic surgery. Is this, is that happening in your field?
No, not to date. And look, I mean, the hand is filled with complex anatomy, and not that other spaces aren't, but there's a lot of positioning issues with the hand and variances in anatomy that would make it challenging to do robotic surgery as it stands in its current state of technology. So not so far.
So robots aren't going to put you out of business just yet.
Not just yet. No.
That's good. Are you ever surprised you get in there and you see something quite shocking? I mean, are you like, wow, that's bad, or,
Yeah. Yeah, absolutely. And it takes experience to recognize what is atypical, right? So when I had somebody have an oddball tendon that was in a different space where it shouldn't have been in the carpal tunnel, and that turned into a surgery where we had to go and remove a muscle belly that was way up here. Now this person has like these, 1 in 10,000 oddball tendons, but had we not recognized that there was atypical anatomy, we wouldn't have known to be able to trace it back up and remove that muscle, because not only was there compression through the carpal tunnel, but there was also compression up here. And if we would have not seen that, then, or been able to recognize it, I should say, then that patient would still be symptomatic and they'd be scratching their heads knowing that we did a good carpal tunnel release, but didn't take that extra step. So, or there can be, unusual branching patterns to the nerve that you have to be cautious of. And so that's where experience plays a role,
Yeah. So the human body, it can do kind of funny things sometimes, huh?
Yeah. 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 There's some, what we call them aberrant muscles, or tendons that can be, they're known to exist, rarely seen. And, they can be a contributing factor to someone's presentation, and not always just the overuse.
Is that like a genetic? I mean, is it run in the family or?
Yeah. They're, you might argue that these were muscles that were present when we were climbing in the trees, and occasionally they still pop up once in a while.
Huh. What kind of woodwork do you do?
I do, well, I have a full cabinet shop, which means pretty much every heavy piece of machinery you can think of, but primarily I do wood turning. And so
Like lathing?
Lathe. Yep, you got it.
My grandfather did lathing. Like, what do you do? Do you make lamps? What do you make?
Mostly like vases and the like decorative vases, some what we call segmented turning pieces. I just made this humongous vase that kind of looks like a large urn. It's about, I don't know, over 30 inches tall, 24 wide, big, heavy piece, dangerous.
Wow.
But, yeah.
Do you
Most of the stuff is smaller.
Do you sell them?
No.
No? You just like
too much time invested in the piece to part ways from it.
Oh, it's like for your personal, and just like you make them and enjoy them.
That's right. No, it's like kind of an artistic outlet, to be able to do those things. And it's nice because I'm right in the garage. So if the kids are out playing and somebody scuffs their knee, I'm not out playing golf somewhere. I'm just in the garage. So it's something I can do and still be close to my family and still have my little thing to do too.
We've started an Instagram account for the center, and I would love to see some of these vases on that Instagram.
Absolutely. We'll get you some pics and post them on there.
That's awesome. Dr. Ciaccia, thank you so much.
Oh, it's been a pleasure. Thank you very much.
Yeah, this is so great. All right. Well, thank you so much, and I look forward to maybe doing this again real soon.
Absolutely. Yeah, we'll come up with another topic to hit on, something else that's common for folks, and see if we can get some information out there.
All right. I love it. Thank you so much.
All right. Thanks.
All right. Bye.
Have a great day. All right. Bye-bye.